I ask you to please welcome Dr. Barfield.
Well, so I always approach this topic as a beginner, as a learner. Anytime I walk into the room of someone who is experiencing illness or suffering or dying, I walk in ready to be surprised and ready to learn something. And very often, I walk out humbled. And so some of what I want to talk about today is meant more to provoke discussion than to be some sort of instruction on how to be human. Because I still have so much left to learn, I wouldn't know how to do that. So I look forward to our discussion. Was anyone at the thing last night? Oh, okay. So this is one of the girls I was talking about. Allie is, she was a kid, like I mentioned, that I treated with an experimental cellular therapy for relapsed neuroblastoma after she had struggled with the disease for 8 years. I don't have a picture of Emma Grace here, but she was a very important part of the whole dynamic that taught me how little I know about suffering and about dying and about being present to people who are facing such difficult sorts of things. But over the course of several months, I watched Allie and her friend, who I had transplanted with the same therapy, die. And it was a terribly painful experience. It was a remarkable experience as a research physician because I watched their neuroblastoma melt away. And so the disease that I was trying to treat responded in an amazing way to this last-ditch therapy that we had. Unfortunately, the therapy tore them up, and they couldn't survive the therapy. And so it was an incredibly challenging time in my own professional life, like I mentioned last night. One that really brought me to a place in my career where I asked, is this the right place for me? Am I the right person for this job? When I went into it, I thought, this is exactly what I'm supposed to do. This is perfect. I'm glad I finally found what I'm supposed to do. And it was difficult to be on the edge of realizing that maybe I am not going to be able to do this. Maybe this is too hard for me. Because if I have to feel like this for the rest of my career, I can't do it. But if I'm going to have to distance myself from the reality of what's happening in the rooms, I can't do that either. It doesn't feel authentic. It doesn't feel real. And so I felt really stuck. Now, as I've thought about how we got here, how I got into a place where I could actually have a front row seat on someone else's major life crisis and feel equipped with so few tools to respond in a satisfyingly human and compassionate way, I had to ask myself how I got there. And a large part of that had to do with thinking about the way that I had been formed, the way I had been trained. Now, obviously, I come from the United States. I come from a different system. And I've been learning a lot of fascinating things about the similarities and the differences between our training systems. I tend to be very critical of our training system, but I criticize as a friend, as somebody who hopes to make it better. So a lot of what I'm going to talk about, or at least touch on, is going to reveal problems that I see in my own formation as a physician, problems that I've had to spend some years overcoming and that I'm continuing to overcome because I continue to find challenges that I think grow out of the way I was formed as a physician that have to be addressed along the way. But it's certainly the case in the story that we tell about the history of medicine that before having very many sort of treatments, really effective therapies, where our toolbox just had a few tools in it, a lot of what we valued was the relationship between the caregiver and the person who was suffering. there was a deep sense that understanding who the person was in front of you mattered if you were going to meaningfully ask and answer the question, what can I do for you? What kind of help do you need? Without understanding who is in front of us, there would be no way to adequately answer that question. But as we went along, medicine began to develop techniques for understanding physiology, for understanding the body as such. In the late 1800s, if you look at the history of the development of these instruments, you begin to see instruments that measure, without touch or without other sorts of interactions with the body, the heart rate and the respiratory rate and other sorts of parameters of physiology. In 1897, there was a revolutionary technology, and we take so much for granted because we're just around it all the time. But the idea that you could see the inside of the body by using x-rays and just have a picture of the inside of the body was astonishing. In the early 1900s, we developed the electrocardiogram so that we could measure the activity of the heart, the electrical activity of the heart. But again, a technology that didn't really require us to touch the patient or interact with the patient. Clinical laboratories began to grow up so that we could take a piece of a patient, just a little piece of tissue, and take it into another room, into the laboratory, and begin to make diagnoses without any reference whatsoever to the person who might be sick at the time. From the mid-1950s on, part of the gold standard of clinical research began to be the randomized clinical trial. And we started emphasizing evidence-based medicine. And one of the most important things in a randomized trial is that precisely what you're trying to get rid of is particularity, because you want to come to conclusions that are generalizable to large populations. And this is an incredibly valuable approach to medical research. But again, there's something that's missing, and it's that missing thing that caused me so much trouble when I had my own personal break as I took care of Allie and Emma Grace. Now recently, I've come across a book that I want to recommend to you if you're interested in a philosophical critique of medicine. It's called The Anticipatory Corpse. But I'm going to give you a 3-minute summary of it so that you don't have to read it if you don't want to, because it's like $26. It's by a guy named Jeff Bishop, and I was so impressed with his critique that I called him up and asked him to be my friend. And he said that he would. And so we've become friends. And I've gotten to know this guy. He's an internist, an incredibly experienced physician, who also has a PhD in philosophy. And he brought his decades of experience as an internist and his training in philosophy together to do what I think is a very deep critique of medicine. But here's the stick figure version of it. And I was just telling Phil, who teaches, actually this is his book, The Roots of Sorrow, A Pastoral Theology of Suffering, that looks absolutely fantastic, and I cannot wait to get a copy and read it. But I was just telling him the same thing. So here's the stick figure version of how a physician's mind and imagination are formed. And this is the basis of his critique. So as a medical student, when I went to medical school, my first sort of exposure to medical formation was anatomy. And my first patient was dead. And so I learned what it looks like for molecules to be static. I learned where they all were, where all the pieces of the body were. Then I went on to the next phase of my training, which was physiology. And in physiology, what I learned is how those static molecules begin to move. And when they're moving, that's what we call life. And so my definition of life was that instead of the molecules being static, now they're moving. Then I went on and I took a course in pathology. And in pathology, what I learned is what happens when the molecules go the wrong direction. Then I went on to pharmacology and to my clinical rotations, where I learned how to intervene to make the molecules go in the right direction. And then I graduated, and then I was a doctor. And The challenging thing that Jeff Bishop wants to bring into our minds is that my definition of life within the medical system was, well, moving molecules moving in the right direction. And is that a 15? Does that mean I have 15 minutes left, or I've talked 15?
15 minutes left.
15 minutes left, okay. I'm going to have to speed this up. So my definition of life is molecules moving in the right direction, and the definition of my vocation is when molecules are moving in the wrong direction, making them move in the right direction. But if that's the extent of my framing, of my sense of what life is and of what my vocation is it any wonder that when I have a patient, no matter, without reference to their goals, without reference to who they are, without reference to anything about them, if I see their oxygen level go down, I put a nasal cannula on. If I see it continue to go down, I put a face mask on. If I see it continue to go down, I put a non-rebreather on. If it continues to go down, I put them on a ventilator. If it continues to go down, I may put them on ECMO. But all of these steps are responding to a physiological reality, trying to get the molecules going in the right direction. None of that, though, has to do with the deep question about who it is that's in front of me, what is actually the purpose of our actions, what's the end that we're moving towards, and what is the rest of their story. How does the rest of their story bear on the kinds of deep decisions that we're making? And this is true especially at the end of life. These aren't the kind of points that you would bring. If I break my arm and I go to the emergency room, what I'd really like you to do is just give me a slug of morphine and set my arm. So it's not in every setting that you're going to be asking these kinds of questions or having this kind of critique that Jeff has. But it becomes deeper and deeper, more and more apparent as people move closer and closer to the last part of their life. Now, in the United States, one of the things that I've observed is that, working off of Jeff's critique, a very common course that a patient will take is that they start out sort of with a modest or maybe partially affected health status, and then they have a crisis, and then we do lots and lots of things to get the molecules going in the right direction, and they recover, but not quite to where they were, and we discharge them with some instructions that they don't follow. And then they have another crisis, and they come in, and we do lots and lots of things in the hospital to get the molecules going right, and we discharge them again, but not quite as well as they were. And they keep having this dip, and yet each time it happens, they get a little bit worse until finally they die. And along the way, we see this increasing symptom burden, where the suffering grows, and where the opportunities to do non-medical things are diminished, and where things may be so complex that they can't see how to make a decision, and they don't understand the consequences of the decisions that they're making. But a lot of this is motivated by something that both the parents and the physicians, and sometimes the nurses, although nurses seem to me far better formed than physicians in my experience in the United States. But one of the things that seems to be the real kicker issue is this: it's dying. It's terrifying. It's hard to talk about. And it's especially hard to talk about in abstraction from any sort of account of what kind of world we live in, or who I am, or what my history is, or what my faith is. What do I believe about God? Do I believe there's a God? If I don't believe there's a God, what do I think about death? All of these sorts of things seem incredibly relevant to decisions that are related to these crises that I just mentioned. And yet, as a physician, I found myself referencing the person's story far, far too infrequently. And I realized that the conflict that I was experiencing is that my training was to trust objective data and laboratory results and numbers and statistics and these sorts of things. But human beings experience illness. Good gracious, why? Somebody's trying to get in touch with me. I'm going to see if I can turn this thing off. Sorry. All right, there we go. But human beings don't experience their disease in terms of biology or numbers or statistics. They experience it in terms of what they're afraid of, what they're going to lose, what their relationships are, what their hopes are. And this is what I take to be a sort of broad understanding of what I mean by their story. That's how they do it. And by the way, I experience my vocation in relationship to the rest of my story also. One of the things that I've come to as a physician is that in the system that Jeff Bishop describes, and in the system that I gave you a caricature of, it's very easy for physicians and nurses to begin to feel like technology dispensers instead of moral agents. But I am not a technology dispenser. I'm a full-on human being engaged in the drama of illness and suffering and dying. I approach it with my own hopes, my own fears, my own uncertainties. And the uncertainties are the thing that really sometimes drive my most uncomfortable moments. If we don't pay attention, though, to this richer notion of who the person is, a lot of stuff can happen. Sometimes we'll end up emphasizing the wrong things. Now, I can't tell you how many times I've been in a situation where I'm in the intensive care unit and there's a patient who is clearly getting worse, who's clearly moving towards death despite our very best efforts. And I'll hear someone, usually a resident, come in and say, "Oh, good news, the white count looks a lot better today." Well, the white blood cell count may look better today, but the patient sure doesn't look better today. And if we're going to emphasize these kinds of little things and not ignore the larger picture, we can end up emphasizing the wrong things. If we're not paying attention to patients, we may have no idea what they most deeply value. We may have no idea what their goals are. We may have no idea what they're willing to risk to achieve a goal, or if they understand the true consequences of their medical choices, the other sorts of things that they would much prefer to embrace, like being at home, for example, or being with a loved one, or something like that. Unfortunately, a lot of times, families and patients don't know exactly what it is they need to say, because as y'all know, medicine is so complex these days that it can be very difficult to see your way clearly as you try to make decisions. And I don't know what it's like in Canada, but in the United States, we find it incredibly difficult to talk about death. Doctors find it difficult to talk about death, and nurses, I hear on a regular basis, after they've sat in on a conversation with a physician who was supposed to go in and talk to the patient about what's really happening, walk out frustrated that the reality of the situation has not been addressed, and they feel like the patient still doesn't understand what's going on, and that they're making deep decisions about their lives that may cost them opportunities without recognizing the truth of the situation, and that can be desperately frustrating. Now, part of the problem has to do with where we encounter death these days. So it used to be that death was something that we encountered in the home. It happened very frequently, in part because we didn't have any good medicine. Now, most of death and dying is sequestered in the hospital, at least in the United States. And again, I'd be interested to hear about Canada's experience. But in the US, when I think about the places where we encounter death, you know, it's certainly the case that we encounter it in video games. The thing about video games is that you are dead for however many seconds you get as a penalty, and then you pop back up. We encounter death not infrequently in TV shows like South Park. I don't know if y'all get South Park up here. Yeah? But Kenny dies in every episode, and he always shows up in the next episode. Poor Kenny. Celebrities. Again, I'd be interested in how it impacts Canada, but in the United States, when people like Whitney Houston or Michael Jackson die, there's this overwhelming outpouring of shock and grief that then yields a commemorative album that everyone buys, and then it sort of fades away, and we go back into an overall cultural denial of death. And then if anyone's been watching the healthcare debates in the United States, wow, we've had a hard time down there trying to figure out what to do. But at a point where we had a provision to allow caregivers, medical caregivers, to be paid to spend more time helping people understand their options, that was turned into an absolutely political landmine. They were called death panels. And the rhetoric around death panels essentially killed this option, this possibility of increasing the way that we talk with people about these difficult sorts of things. Now, in the end, it's probably true that Woody Allen has yet again hit the nail on the head. I don't want to achieve immortality through my work. I want to achieve immortality through not dying. The thing that I want to leave you with is just this one point. I think we cannot understand the meaning of a decision that a person is making in the face of suffering or death if we don't consider the whole person and their story. And for those of you who are either in medicine or nursing or thinking about going into medicine or nursing, I also don't think that we're able to fully embrace our vocation unless we reflect on the place of that vocation in the context of our whole story. Now here's in the last 3 minutes, I may take 1 extra minute, just a couple of tips that I sometimes throw out to residents or other trainees. And one is to be mindful of projection. Just because we think we see something doesn't mean it's there. And it may very well be that we're projecting into a situation our own sense of what's valuable. Being aware of that is helpful. It's important to learn to be patient, even when things don't go the way that you want. It's important to remember that sometimes we slip. And I do this in conversation on a regular basis where I have to say, you know what, that came out wrong. I didn't mean to say it that way. Can I start over? I just put my foot in my mouth. There's usually a nurse to my side going like this. Pay attention, though, to the wonder of the thing. As we get incredibly busy, we can sometimes forget just to look at the beauty of what's in front of us and the incredible privilege that we have being present to this kind of deep human experience. I encourage people in medicine or nursing or any sort of profession close to illness or suffering or dying to be courageous and to keep a sense of humor. And to remember that a lot of us go into medicine and healing professions because we want to be guardian angels. We want to come in and rescue and to help. But it's also really important that we remember the impact that it can have on us. And sometimes in our brokenness, we need help. Now, I'm actually out of time, and so I'm going to skip these 2 slides and just encourage us to strive to imagine each other's worlds and to be changed by what we discover. I apologize for this scary pig. And I'll stop there. Thanks. Sure.
Is it okay to cry in front of a patient as a healthcare provider?
Yes. And almost every question that I get that begins with the phrase, is it okay to do blank in front of a patient? It's almost always the case that probably the best answer is yes, sometimes. And I think that one of the most important aspects of truly being a servant to people who are in need is doing the courtesy of being fully present so that you're paying attention to who it is that's actually in front of you and to the reality of their situation and what they need. Because there are times when somebody really doesn't need you crying. And I've had situations where it would have been probably the wrong time to weep. But allowing myself to be vulnerable and to express my sorrow at someone else's loss. Allowing myself to do that has become something that's enriched my own practice as a physician. But I do think it's important to be prudent and aware, because there's not a one-size-fits-all for any question, anything we do for patients.
Well, thank you. We've kicked off the questions. Are there other questions? Can I pass the microphone around?
Dr. Barfield, I'm studying social work at McMaster, and I just finished a placement at the Divinity Cancer Center on the mountain. I worked in the Palliative oncology unit. And the biggest difficulty that I found was how to approach the subject of hope with patients. Because I really come at it from a spiritual kind of faith perspective. So I wondered if you could speak to that a bit of your own experience.
Absolutely. And again, I hope that, see, I'm giving you an example. I hope that some of you would comment after I give my comment on your perspectives on both hope and false hope, and how to tell the difference between those two. So generally speaking, when it comes to hope, I see hope, or I hear hope used as the reason not to say true things about a patient's situation, because we don't want to take away hope. And I understand that. I understand that as a motive. But the question becomes, hope for what? If I have a patient who has been transplanted for leukemia and they relapse a month after transplant, that patient is not going to be cured of their leukemia by anything that I have to offer as a physician. That's important information for a person, because if they're not going to be cured, there may be other stuff that they need to do that they think is important in their life. And if I don't let them know the truth of their situation, because I don't want to take away their hope, what I actually end up doing is making it impossible for them to decide what's most valuable in the last part of their life. And that kind of hope is not a hope that I can legitimately offer, because I know they're not going to be able to be cured by anything that I have to offer. So that's a kind of hope that I find problematic. But there's something else that can be said about hope. There are actually a couple of more things that can be said about hope. One kind of hope that I hear is a hope for a miracle. And now I'm a Christian. My background, my frame is a Christian frame. And within that Christian frame, I very much believe in the power of God to do whatever God wants to do. And so my frame, my worldview, by no means bars the possibility of miraculous intervention. That said, the function that a hope and a miracle often has in our intensive care units in the United States, as I've watched it, has been to allow a sort of reason for continuing to add technologies in a situation where the medical technologies are not going to help, and in fact are going to cause positive harm. So there's a question. What do we do with hope for a miracle when we're thinking about whether or not to add on the next technology? And I'll mention something else about that in just a moment. But there's a third approach to hope, which is the approach that I take, or try to take when I'm able to shut up long enough, which is very hard for me, as you can tell, because I can't even finish this sentence. Oh, wait. All right, there we go. I can't tell you how many times I've been in the intensive care unit talking with a family who has a loved one who is not doing well. And after some conversation, I'll look at them, and it'll be something along these lines. I'll look at them and I'll say, well, what are you hoping for? And they'll say, well, we're hoping for a miracle. We're hoping that he gets better. We want him back. Now, if at that moment I jump in and start explaining about how he's so sick again and why he's on the edge of dying, I've completely missed an opportunity. But sometimes it can go like this. What are you hoping for? Well, we're hoping for a miracle. We hope that he gets better. And then I don't say anything. And there's a pause. And there's some thought. And then they say, but if he's not going to get better, what we're hoping is that he doesn't suffer. And by being quiet just a little longer, I've given them a chance to explain to me the context of their hope and the meaning of their hope. And very often, at that point, we can begin to have really constructive conversations, even while we hope for a miracle. We can have constructive conversations about how to achieve this other hope if it turns out that this is his time to die. And I find that to be an incredibly helpful approach to the language of hope. Now, the miracle, the hope for a miracle, I find to be really challenging, especially if it's set up this way. If it's set up so that I hope for a miracle, the condition for me getting the miracle that I hope for is that I be faithful. And the evidence that I'm faithful is that I continue to add on medical technologies in order to give God time to achieve a miracle. That puts someone in a real bind, because there's absolutely no way to stop adding on medical technologies without cutting off your opportunity to have the miracle that you hope for. Because that is the expression of the faith, and the faith is necessary for the miracle. And so in that kind of complex dynamic of hope, I really have to wake up and pay close attention to what's happening, because I want to simultaneously show them the way in which God doesn't require my ventilator to do a miracle. And the adding on technologies is not necessarily the only expression of faithfulness, without stomping all over the experience that they're having in the moment. And sometimes I do it well, and sometimes I do it not as well as I should. I'm still learning how to do that. Has anyone here had any experiences close to that, as nurses or physicians, that you'd be willing to either share something about or give us some advice on how to approach it? You seem to have.
I had a patient the other day, actually it was just yesterday, he's 31 years old.
Actually, I want to give you the microphone so that you can talk. Yeah.
I'm a second-year nursing student, and I'm also at the Divinity on a medical floor, an alternate level of care floor. I had a gentleman yesterday who was 31 years old with a very aggressive, very large melanoma tumor, and he is going into palliative care, hopefully next week. But he refused all treatment, even at the beginning. They caught it early, about a year and a half ago. So very treatable, but he refused everything. And I found that really hard as a healthcare provider, where I felt very frustrated because there was so much they could have done for him. And I found it very hard to give him any kind of hope because I felt like he had chosen not to hope. And it was, so I don't really have any advice or anything like that, but it was a little bit eye-opening for me because of that.
Yeah, that's quite a story. And And I think in that setting, it's also fair to ask whether there are other things. I mentioned the parent who will go on to say, well, if he doesn't get better, what we hope for is that he doesn't suffer. There are other sorts of hopes that people have. And I've had patients, I remember one patient that I had, a 14-year-old with metastatic Ewing sarcoma. And her dad, her family had a lot of problems. Her mom would break into her morphine, trying to get it for herself. Her dad had left them, years before and showed up towards the end of her life, had been in various ways abusive to her, was abusive to the staff, and so I had him banned from campus. And one day I was in her room talking with her, and I said, is there anything else that we could be doing? Is there anything else that you need right now that would help you with this? And she floored me. She said, I need to talk to my daddy. And that was hard for me because I didn't like this guy. He was mean to all my staff. He was mean to her. He had been abusive to everyone in his family. I'm fairly certain he had been sexually abusive to her. But she needed to talk with her daddy. She was at the end of her life. I said, all right, I'll lift the ban. He can come on campus. And he did. He came on, sort of shuffled along, went to her room. And for 2 hours, they were in there talking. Later on, when I talked with her, she didn't give me the details of the conversation, but it was very clear that something important had been accomplished there. Now, it wouldn't surprise me at all if what she had hoped for was to find a way to say to her dad the things she had needed to say for years, and to hear from him something she's needed to hear for years. And very often, there's a hope for a kind of reconciliation that it's very difficult to bring out into the open, especially if we don't have a relationship of trust. And so sometimes there are hidden hopes, and we should be aware and open to that, and even create space for people to express them and pursue them, even if they don't want to give us the details. To say, yes, there is something that I'm hoping for, and yes, you can help me get to it. That's a great gift to people, even if they don't want to talk about cure. I'd be interested from a social work perspective. Have you had other thoughts about the issue of hope? Do you have any responses or critiques of these past several ideas?
My undergrad is in literature, and I came to social work just trying to understand the intersection of creativity as it relates to religion and my faith, and how I can tangibly, I guess, help people, for lack of a better word. So that actually came out a lot when I was at Divinity, just being able to create that space, like you say, for people to express hope. And a lot of the times it wasn't about me trying to find something to talk about or to just approach the subject of hope because I know they were going to die in a short amount of time. Really, it was about the patient expressing hope to me and giving me more hope in the process rather than the other way around. So.
I really like the idea of including yourself in the dynamic in that way, because that's a part of what I really hope to emphasize today, which again is our own humanity as we participate in this very intense and very difficult kind of work and calling, which we're continually learning about. Did you have any thoughts about hope? You've watched people for quite a while.
I'm always reminded about something written by David Kuhl, and I don't know if you've come across David Kuhl. He's a palliative medicine physician in Canada and a psychologist. And one of the things that he reminds us about ourselves is that as caregivers, we hope to. I think when somebody says, I hope to live longer, the problem is as a physician, I put on my almost parent hat that says, oh, but you're not going to, right? And as you said, if you just pause, people tell you their hopes. But if I really listen to myself, when I have a young patient who says, I hope I'm going to be cured, I hope that. You would have hoped that Allie would have been cured or lived longer. We're right there, and as nurses, you hope that your patient gets better or doesn't suffer. And so sometimes I say to my patients, I hope that too. And that's where our hope goes. We know sometimes that maybe that's not going to happen and we're going to move in a different direction, but our hope is still there. Yeah.
My comment towards hope is not necessarily, or I just want to share an experience where kind of, this was as me as a nursing student in my 4th year, and I was working in the palliative ward. 56-year-old gentleman who was in his, and he was in end-stage liver cancer, asked me the question, am I going to die? And it just felt like that I was in this position where I was robbing him of all hope, and I didn't know what to say. And he took my silence as a cue for yes, and he began to sob, and he started crying. I had no way of stopping him, and I didn't know what to do. And I just wanted to bring up this comment because I wouldn't know, was there something else that I could have done? Was there a different approach? Should I have gone and said truthfully what was going to happen? Should I have gone and dodged forward? And maybe if you can comment on
that. I think that when you show up, you do what you can do, and I personally think that silence is very beautiful. There's not enough of it. The only thing in that situation that I can imagine to have been a true mistake would have been to say, oh, of course you are, of course you are. They're always looking for new things. Of course you're going to be cured. You're not going to die. We want that to be the case. We hope that to be the case. But the one thing we can't do is lie. I think lying has no place in something with stakes this high. And I only get to die once. And if somebody lies to me and makes me miss all of the experiences leading up to my death to keep me from experiencing pain, I'm going to be highly upset, because that is not fair. And something will have been taken from me. So I think silence is great. There's no reason why you need to say words. Words aren't the only way you communicate. And I also think that the result, which is that he cried and cried and cried and cried, is not a bad result. Because he's looking at having to let go of everything he's known. Everything. Why wouldn't you cry? Even for someone whose hope is that death is not the end of the story. Even for someone like that, someone like myself, you better believe I'm going to cry at the idea of letting go of everything I know and everything that I love. Here, I love this earth. I love my life. You know? So I think crying is good.
Yeah, I really appreciate that point, and I totally agree with it. Because I feel like sometimes as healthcare professionals, or just people in general, we feel like we have to stop people from crying to make them feel better or to fix something, but that's not always our job. And although we might try and fix something and make a patient's quality of life better, sometimes just walking with them is really the role that we're there to play. So although you're not fixing anything, you're walking with them, and then you're being there with them through those tough experiences. So maybe just that silence, that presence is the only thing you can do. It doesn't always feel like you've done something, but really you have.
I couldn't agree more. And that fostering that presence is something that is extremely difficult. It's beautiful, and it's an art. It is a form of spiritual and psychological maturity. It's a form of depth, of human depth, to be able to be present in silence when another person is allowing themselves to be vulnerable in front of you in the form of weeping and expressing their grief. And so it can be incredibly powerful to do. We have 1 minute and 45 seconds.
Having worked in pediatrics, how do you necessarily deal with discussing hope with the patients themselves as opposed to the parents? Obviously, there are some patients that may be too young to fully understand the magnitude of what they're facing. They may have a hard time understanding what death is, and they may not want to believe that they may lose their life. And yet, as a parent would want to have honest answers about that. You know, what can they do for their child? What is the prognosis? How do you deal with potentially running two entirely different scenarios for the same thing, or how honest are you with the patients?
That is a very good question, and it's one of the hardest things I think that we do when a parent says, look, I want to know exactly what the prognosis is, I want to know what to expect so that I can plan, but under no circumstances are you to tell my child or talk with them about this. Under no circumstances. And that's where shuttle diplomacy comes in. I ask permission from parents for each step of the way, because one of the things that I don't want to do is to rupture their parenting relationship in the last weeks or months that they're going to have to parent, because they're not going to be able to parent their child into marriage, parent their child into college, parent their child into careers. This is the last parenting they're going to do. And if there's one thing I'm not going to do, it is to rupture their last experience of parenting. And so I'm going to remain responsive to them and let them give me signals and guide me about how to do it. At the same time, I'm going to let them know from my experience some things that may help them to make wise decisions that will make a big difference. And I know this is going to take 1 extra minute, but I'll tell you this study that I've found quite helpful. There's a study that was published in the New England Journal of Medicine, and I think that's right. And it looked at 430 parents who lost children who were of an age where they could speak about death and dying. And they asked 3 questions, and they were 3 incredibly simple and interesting questions. The first question they asked is, did you talk to your child about the fact that he or she was going to die? Turns out that about 1/3 of them talked with their child, about 2/3 of them didn't talk with their children. Second question they asked, do you regret your decision, either to talk or to not talk? And among the 2/3 that didn't talk to their children, right around half said, we regret that we didn't talk to our child, and we wish we had that moment back. Which means that right around half said, yeah, we think that was the right decision to not talk with our child. We were happy with how this went. Among the people who talked with their children, none regretted talking with them. Then they asked the third question. Among the people who regretted talking to their child, what was the predictor that they would regret? What sort of thing could have given us a clue that later on they were going to regret not talking to their child? And it turns out that the biggest predictor that they had was that they suspected that their child knew that they were going to die, and yet they still didn't talk to them. Now, there are many times when I'm talking to a family who says, we absolutely don't want anyone to talk to our child about dying, where I'll say, I can understand that. Would it be helpful if I were to just let you know what some other parents have experienced, not to change your mind, but just so that you know what their experience was? They almost always say, oh, absolutely, I'd love to hear what they have to say. Don't talk to my child, but let me know what they say. And we negotiate along the way. And I'll ask permission. Is it okay if I ask your child what they understand about what's going on? In very open terms. And they may give me permission to ask a few questions like that. But I always respect the parents, again, because this is their last chance to parent. And I, for myself, think it's presumptuous to break that. All right. Thank you all very much. I've enjoyed being with you.